idea came to my mind, say, when I was training, and the main emphasis has been, I'm a surgeon, I like to do surgery, I have been trained with surgeons, but I realized only 7% of glaucoma patients require surgery, 93% don't. And I was thinking, how can we reduce that transition from 93% to 7%? Can we stop those people reaching to the point when they require surgery? And across the globe, I'm originally from India. I'm trained in New Delhi. And in New Delhi, then I did my training in Scotland, Oxford, Birmingham, Moorfield Hospital, London. I've been to Switzerland to train with Switzerland. Everywhere, the main emphasis has been on the surgical aspect. Everybody's talking how great their surgeon, how great their surgery is. I'm a fantastic surgeon, I'm doing this and doing that. And I thought, yes, I've obtained all those skills, but can we stop that transition? Can we give more time to people? More time where they can understand things clearly. What they are afraid of asking in clinic, they should be able to ask me. And like today, we have about 75 to 80 people in the room.
More,
Nearly 100. So today, 2.5 hours of my time equals to 250 hours of education. And that's what is so important, so unique about this meeting. I'll talk about the Glaucoma Support Group website later on, because we are going to officially launch the website of Glaucoma Support Group. Today is a launch day for our Glaucoma Support Group website. And this idea came to my mind while doing these meetings, that not everybody is able to come the day I'm free, the day I have organized the thing. Not everybody is still in these meetings clearly understand few aspects. They forget by the time they reach home. So is there any way I can make things work that they can revisit those moments in their own drawing room, in their own bedroom, on the tablets, iPads? Everybody in this room, I expect, will know somebody who has access to internet. And suppose you don't, you might be visiting local library where there is an access to internet. So we'll be explaining the benefits of how to use this website later on, and what are the benefits. And you can pass that information on to your friends who are unable to come, to your kids, their kids, or some friends' kids who have got glaucoma. So that way, you can generate the awareness very well. I'll take the questions later on. I wanted not too big an introduction because majority of the people have been here, so I don't want to talk about what is a support group, because we have already, this is the 5th birthday. We are going to start with Mr. John Gardner's talk on visual effects of glaucoma. So, John, please come.
So, as you know, glaucoma is often referred to as the thief of sight. And it's usually unexpected. A lot of people do have a family history, so it sort of alerts the possibility. It gives no warning of its arrival, shows no compassion, but it can be protected against. So, the front part of the eye, the window is the cornea, behind that the coloured part, the iris, and behind that the lens that does the focusing, and at the back of the eye we have the optic nerve, which is the site of the damage in glaucoma. The optic nerve takes the signal from the eye to the brain. The front part of the eye, this is a cross-section through it, so the iris here, the coloured part, and the cornea here, they meet at an angle, and it's in this angle that the drainage channels are, a trabecular meshwork. And the drainage channels allow the fluid to escape from the eye. The eye is like a football, has to be pumped up to work, and there's a constant inflow, there's got to be a constant outflow through the trabecular meshwork. So most of the fluid, the fluid is produced in this part of the eye, the ciliary body. It flows through the pupil, and then most of it goes out through the trabecular meshwork. A little bit goes through an alternative pathway. There are lots of different aspects to vision. It's not just about the old Snellen chart, which we're all familiar with. The modern way of testing visual acuity is with a logmar chart, which is a bit more scientific and precise. The confusing thing about the logmar chart is if you have a vision of 0.0, that is normal. If you have a vision of 1.0, that is very poor. It's equivalent to just only being able to see the top letter of the chart. So the logmar visions, it's sort of topsy-turvy. You need to be a little bit aware of that if you get a copy of a letter from the doctor that's quoting a logmar acuity. If it says your vision 0, that means it's good. So reading acuity is obviously of practical importance to our daily lives. Contrast sensitivity, although these letters are all the same size, and but it's plain that the ones at the bottom are faded, and there's less contrast between the letter and the background. This is what typically occurs with cataract. Colour vision is clearly important in different jobs. It's very difficult to be an effective greengrocer if you have colour blindness. You can't tell which of your produce is ripe and which is overripe. Visual field is a major issue in glaucoma. The Humphrey visual field test we're familiar with in our clinics. And this is the sort of printout that is produced from that. So this printout is of a right eye. This dark spot here is the physiological scotoma. That's normal, and it's produced by the normal position of the optic nerve. If you shine a light directly at the optic nerve, there's no response from that spot because there isn't any retina there. But this part is abnormal. That part of the vision there is less sensitive. And the place at which the patient is looking, the fixation spot, corresponds to the middle of this cross. Just there. So another aspect of vision is we don't want to have double vision. The eyes have got to be working together as a pair for the best vision. And that enables us to have depth perception, judging fine distances for threading a needle, building an airfix model. So the high pressure causes damage to the optic nerve at the back of the eye. And this is a normal optic nerve. The central cup is relatively small compared with the overall size of the disc. But if the nerve fibers are damaged, then the cup becomes enlarged, because the nerve fibers are all concentrated in the rim of the cup. So this has got a very healthy rim. This one here, the rim has mainly been lost. So there's a huge cup. And in glaucoma, what happens is that the damage to the rim here corresponds to the visual field defect. And of course, the damage is at the bottom of the disc, but that corresponds to the top part of the visual field, so everything's inverted and left to right with the way that the optics of the eye work. Right, just check my notes. walk around using one eye or the other. We walk around with both eyes open. So any defect in one eye can be compensated by the good vision in the other eye. So this is the concept of integrating visual fields. When we test the visual fields in the clinic, it's one eye at a time, but imagine overlapping the visual fields. That gives you the actual practical, real-life idea of what's happening with the vision. So, for example, here's a left eye, most of the top vision is missing. Here's a right eye, most of the bottom vision is missing. When you overlap them, it's virtually normal. There's just one little spot there where both visual fields are missing in the same corresponding place. And that does give a vision in the binocular visual field. So here's how that might appear with a visual scene. Here's the left eye, the right eye, overlap them, the patient or the individual feels their vision is normal. Now, a lot of the pictures you see of glaucomatous visual loss on the internet are misleading, and in fact worse than misleading, they're dangerous, because they show pictures of black tunnel vision or big black missing places in the vision. And people look at those pictures and they say, well, that's not me, so I must be okay. That is the problem with these images and why they are misleading. So, what does glaucomatous visual loss appear like to the affected individual? And this is a study done at Moorfields where 50 patients, all of whom had visual field defects in each eye, they were asked which of these 6 pictures is most like your vision. And a quarter of those patients chose the unmodified image. In other words, they thought their vision appeared to be completely fine. Then others chose, some of them chose a bit of blurred tunnel or blurred in parts, or even missing parts. Nobody chose this one with the black patches, and nobody chose this one with the black tunnel vision. Now, all these people had visual field defects in each eye, and nobody chose these two, which are the typical pictures you see on the internet or in books about glaucoma, whether people are trying to indicate what it's subjectively like. The thing is that these are positive scotomas. They're missing parts of the vision which stand out at you as immediately obvious, they're positive. Whereas glaucoma produces negative scotomas for which we're not aware. And so this is the most typical picture.
You want to use this stick again so that we can...
No, I think it's going to. I'll do my best anyway. There's a bit of internet, so I'm just going to find see if I can find. Yeah, I think we'll just leave it in. Sorry. Yeah, just to load a new screen, yeah, that can load it.
As John is saying, the main message is that many people think their vision is absolutely normal while they are having the visual field defect. If we've got a visual field defect in one half of the one eye and another half of the other eye, and it is progressing, it's not that there's no concern. And that's where problem comes when you see us in the clinic. We say, oh God, your visual field is progressing, and you think, why he's bothered? Because when it reaches to the other area, then suddenly DVLA will stop driving. We'll be talking about driving, and this video is very useful video. We'll just show that video, that's why I'm talking in the meantime. It's important that we control that change. If you got a small field defect, we don't want that field defect to get worse with time. And the reason we get the visual field defect, because your nerve is getting damaged. You know, as we showed in one of the pictures, I'll show probably again. Your nerve is essentially a cable which is connecting your eye, which is your camera, and television is the brain. And that nerve contains about 2 million fibers typically. It varies between 1.6 million to 2 million. And every single day from the age of 10 years, we lose some fiber due to natural aging process. So whatever we may do, we may not be able to stop that process. But when somebody has got glaucoma and you've got high pressure, you might be losing 5 times to 50 times to 1,000 times, depending on the pressure and your eyeball characteristics. So are we ready for the video? I just interrupted because while we were loading the video. So.
It's just these particular pictures which I think are very important. Yeah. So I think these particular pictures are very appropriate. This is the true life scene. Then that's the visual field of the individual with the true life scene. There's the little physiological normal blind spot. This is what happens when you lose that amount of visual field. The children disappear. You just see the child's head. This car has virtually disappeared. And with more severe visual field loss at the bottom, the loss is even worse. And what's happening is the brain is filling in the missing patches with what seems to be an appropriate background, a sort of grey tarmac type appearance. And it's because of this filling in effect that we have these negative scotomas that we're unaware of rather than the positive scotomas. So these are the words that people used the most frequently when they were surveyed about how their visual loss with glaucoma affected their life. Driving, reading, risk of falling, concerns about mobility, but also difficulty with the computer, walking around the home. Somebody said that the words on a page of text appeared as if someone had poured bleach on them. Somebody said they thought a single-decker bus was coming, but it was actually a double-decker. So this is a representation of the visual fields that overlap. Most of the visual field is derived from both eyes, this central part, some of it from the left eye only, some from the right eye only. And when we're driving, obviously, we need to be able to see right out to each side. This is the test that opticians will do for the DVLA when people with glaucoma notify the DVLA of their glaucoma. The optician has a contract with DVLA to do this visual field test, and it's designed to represent the kind of visual field that's needed for driving. So when we're driving, we don't really need to be aware of spots that are way up high or right down an extreme low part of the vision, but we do need more of the sides. Now, there are 121 points on that screen, and if a point is missed during that test, you get a second chance. If it's missed twice, then it's recorded as a defect. And there's a way of looking at the score, how much disability is present with the test done with both eyes together. And of the 120 points, if you've only got 60 points that you're seeing, then your score is 50%, if you like. And the questions that were associated with the poor score were, do you bump into things sometimes? Do you trip on things or have difficulty with stairs? Or do you have difficulty finding things that you've dropped? I can never remember where I left my keys, but I'm not sure that's quite the same thing. For driving, there are two groups of vehicles. I'm not going to say very much about the group 2. I'll skip over that. But car and motorcycle are the group 1. And people have tried to work out, is it really important having visual field for driving? One study showed that when your horizontal visual field was less than 100 degrees wide, that's when the motor visual collision rate was proved to be higher. The other car came from nowhere. That could be said by anybody in an accident, but perhaps particularly the sort of thing that someone with visual field loss might say. 10,000 drivers in California who had visual field defects. They found that if the defects were just in one eye, there was no increased rate of accidents. But when visual field defects were present when both eyes were tested together, then there double the risk of accidents. So the rules are that you don't need, technically, you don't need to notify the DVLA if you have glaucoma damage in only one eye, provided there's no medical condition in the other eye, such as macular degeneration, and provided you meet the DVLA visual standard. The problem is that meeting the standard involves doing the visual field test, and whilst an optometrist would be able to do that for you, independent of the DVLA, they probably charge you for it. And if you do it through the DVLA, then it's free. So it seems sensible to me to, just for peace of mind, to just notify the DVLA, even if glaucoma seems to be affecting only one eye. The advantage of that is, not that I'm particularly concerned about people with damage in only one eye being a risk on the roads. I don't think they are. The problem is with insurance. That's the issue. If somebody else crashes into somebody who's got glaucoma, the first thing the insurance people will say, well, did you notify the DVLA? And you write back saying, well, no, because the glaucoma was only in one eye. And they will say, well, maybe we should do the test to make sure. And it's just so much aggravation and anxiety. And that can all be avoided by simply just notifying the DVLA. When the insurance company say, do you have any medical problems that might have contributed? You say, I do have glaucoma. It's been notified to the DVLA. I've passed the test. Insurance say, fine, no problem. So it's for other people crashing into you that I see, and their lawyers trying to, get out of the problem. If the other driver isn't insured, they will chase you extra hard for your insurance. And I really think that insurance is something we just want to make easy, not difficult. That's the group 2. So this is the standard for visual acuity. You wear your glasses, you wear your contact lens, you read the number plate on the car, and it's at 20 meters for modern number plates. You're not allowed a telescope device. And the size of the letters corresponds to about 6/15 on the Snellen chart. But actually the legibility is more like 6/10. They're not quite as easy as their size would suggest. That still remains the standard, the 20-meter test, but also there's a requirement to be able to read the 6/12 line at the opticians, which is easier than reading the number plate. That's for group 2. The visual field requirement that you need is shaped like a London Underground sign. There's a circle in the middle, and then there's extensions to each side. Now, the Underground sign doesn't go out far enough, but that's the shape that we're talking about. Lorry drivers, it's a letterbox shape, which is different. So there are various technical ways in which that field test results with the estimate visual field is interpreted as to whether there's a pass or not. But the new change is that the horizontal field must be at least 50 degrees in each direction. You still need at least 120 degrees to each side. But there is a little bit of leniency about where they're missing spots. That's about the missing spots that are not allowed within the central 20 degrees. This is what is acceptable as missing spots towards the edges. So, for example, this results from an estimate visual field test done at the opticians. The question is, are they able to drive a car? Quite a lot of missing spots, these dark ones down here particularly. This centre here is where the patient is looking, and they've got some missing spots down particularly in this corner. Well, it turns out, yes, because there's no missing area in the central 20 degrees. Each of these little marks is 10 degrees. There's one missing spot, I think, but it's not, doesn't count as significant. There's also a false positive, that's right. There were no false positive responses. A false positive response is what happens if someone is trigger happy. They may say, oh, I don't want to fail this test, but I need to press it. That'll be picked up. And if the false positives are more than 20%, then it won't allow it. This one, there's more of these dark spots here, and also the edges are a bit threatened here and here. So this one would not be accepted. There are exceptional cases, so particularly in people who've been driving for a long time, or perhaps someone who's had an overseas driving license in France or Germany, visits this country, and so on. And so there is a little bit of wiggle room. That's for lorries. So with this test that's done at the opticians for the DVLA, I think it's well worth doing a practice run. It is different from the visual field tests that are done in the clinic, which are testing the central part of the visual field. The one for the driving goes right out to the edges, and you have to just sort of be alert to those flashes right out at the edge. And it's also worth getting the hang of not being trigger happy, but also not being too cautious. You don't have to be certain that it flashed before you press the button. It's only probably did or probably didn't. Okay? You want to avoid glasses with thick rims. That'll interfere with these very peripheral flashes. Don't let your glasses slide down the nose. The rim of the glasses will be more obstructing in that situation too. People with dry eyes may well want to put in some artificial tears 2 or 3 minutes before they do their test. Because if your eye is sore and you're closing your eyes forcibly, then that's going to be a problem too. The problem with thick glasses is that the edge of the thick plus glasses, long-sighted glasses, is the edge of the lens produces this patch of invisible visual field. So people with strong positive lenses may be better off with contact lenses where this problem is avoided. If somebody's visual field is borderline, they're just failing, then there are 1 or 2 things that can be done to help. If somebody's very short-sighted, they can't quite read the number plate at 20 metres, their vision may be better with contact lenses or even refractive surgery. And if somebody's visual field is a bit restricted and they're short-sighted, they'll be better off with glasses and worse off with contact lenses. Because glasses for short sight will increase the visual field a little bit. And if someone's really desperate, even though they might not need glasses at all, they could consider wearing plus contact lenses and minus glasses on top of them, to increase their visual field. You get a very slight benefit from doing that. But it is theoretically possible that somebody is borderline. So if there's only vision one eye, you may want to turn your head slightly towards the blind side so that the nose moves out of the way, and people will be doing that naturally anyway. There is the option of trying the test with a different machine as well. Loss of depth perception with glaucoma is something I wasn't very aware of. We think of visual acuity, visual fields, but loss of depth perception is also relevant. I'm just going to talk about briefly some of the other things that can happen with the vision in people with glaucoma. This is this angle closure situation, what used to be thought of as acute glaucoma. So here is the normal side, the vision goes through the fluid goes through the pupil. On this side, the pupil is tightly against the lens, and so the fluid can't get through there very easily. It pushes the iris forwards, and that angle between the iris and the cornea, instead of being a nice wide open angle, becomes a narrow angle here and can block off. If it blocks off all the way around suddenly, then that gives an eye which looks like that. It's usually very painful. The vision goes misty. Usually people feel sick. Sometimes there's abdominal pain. There have been cases of people going to accidents and emergency departments with acute glaucoma who've ended up with their appendix being taken out. The thing with the vision is that, as well as misty vision, classically there is a coloured halo around a white light. So if you've got a red light, it'll just be red. If it's white, then all the colours in the spectrum will be in it, and there'll be a sort of rainbow effect. So one gets halos from cataracts as well sometimes, and from corneal scars, but these are coloured. So that's just sort of the best picture I could find of that sort of a picture. That condition is often treated by making a little hole in the iris so that the fluid can go through that hole. The hole is made with a laser usually, and the light can pass through that hole as a sort of extra pupil. Because it's small, not very much light goes through, but you can get this sort of ghost image effect. And so what we usually do is try and hide that hole under the upper lid so that that extra pupil is covered by the upper lid. An old-fashioned treatment, but still used in some cases with a great advantage, is pilocarpine, which makes the pupil small, so the vision then is dim in dim light. Occasionally people will have so much loss in the lower half of one eye and in the top half of the other eye that the brain can't actually link the two pictures together, and the eyes will sort of slide in their position and give a sort of double vision because there's the loss of fusion. That's unusual. Finally, something which is also not very common in glaucoma but can occur and is certainly much more common in macular degeneration is the Charles Bonnet syndrome. And this is, it's important to realise that this is the reaction of a healthy, normal brain to abnormal vision. So clearly, if someone goes to the GP and says, I'm seeing little animals scurrying around on the carpet, the GP will think something wrong with the brain. But actually, if they say, I've got macular degeneration or I've got very poor vision and I'm seeing things that aren't really there, I know they're not supposed to be there, but I still sort of see what's going on. And the GP will hopefully realise what's going on is this Charles Bonnet syndrome. So it's a reaction of a normal brain to abnormal vision. What the brain is doing is filling in a missing gap. It's saying there should be something there. The vision part of the brain says, I've not got enough to do, I'll invent something. That's not what we want. And the two things that are suggested are a distraction, such as putting on a radio in the background, and Also, it's been suggested that trying horizontal saccades can help. And that means that one can stand in front of a wall, say with two pictures, say 6 feet apart, and flick one's eyes from one to the other, backwards and forwards, about a second intervals like this, repeatedly, 20 times, something like that. That can help make these hallucinations settle. They can be frustrating. Thank you very much.
Thank you, John. One of the principle of this meeting is that we take the questions straight away, some of the questions, rather than leaving it to the end. Has anybody got any questions on whatever we have talked about till now? Yeah.
Once having informed the DVLA of having glaucoma and gone through the test and been successful, is there any requirements of timescale of re-informing other cases?
Yeah, they do that automatically. It's generally, it depends, but it could be 3 years or it could be less. Yeah, but they do that automatically.
You mentioned about the degrees on the horizontal scale for the field vision test. You mentioned 50 degrees.
Yeah, it's 50
and
degrees.
120 degrees.
Yes, that's
How
right.
do those two marry up?
It's 120 total, but it has to be not less than 50 on each side. So if you had 50 on one and 70 on the other, that would be okay.
This is just a photograph of a windscreen of a car, because we're driving, hopefully we're driving a car. And this is the center. It's 10 degree, 20 degree, 30 degree, and just beyond that, when you're sitting on the driver's seat, that's why in the 20 degree we can't have any significant visual field effect. But on that left side, you need to have almost 50 degree or beyond or horizontal visual fieldness. So that was a very good talk, John. Thank you very much. And are there any other questions till whatever we have spoken till now? Because I can just I just modify my talk, every time. So, but the most important fact, I'll just go back. Why we are concerned. I'll come up to a few of the points. Probably there will be some repetition, but it's important. We are concerned because glaucoma is the second cause of, second significant cause of glaucoma, blind registration. If you look at the blind registration, age-related macular degeneration tops the list, and glaucoma is number 2 on the list. If you look at the workload calculation, glaucoma affects 1% of the population. So 1% of population or 2% above the age of 40 years. Ocular hypertension, which is called high pressure in the eye only without affecting the nerve, affects 5% above the age of 50. And there is too much of enthusiasm at opticians. Sometimes they check pressures with a air puff, which is not very accurate. And air puff sometimes overreads. And there are about 50% of referrals are about false positives to the hospital. But that is done largely so that we can pick up as many glaucoma, because other stories, 50% of the glaucoma patients in the populations are not picked up. So that's what is happening to our workload in NHS. If we just calculate about this, stick to the Worcestershire, we should have about 15,000 people. 15,000 people with ocular hypertension or glaucoma. We have to see all of them twice a year. That is 30,000 appointments in hospital setting. The politics is changing. I don't know what will happen to the Conservatives or the Labour who will come, what will happen to the thing. And that's where our glaucoma support groups become important. Few of the things which we have developed on the website, very important. From now onwards, in Worcestershire, the low-risk glaucoma, not defined by us, it's Commissioner's agenda. low-risk glaucoma and ocular hypertension patient will not be seen in the hospital. In the name of care closer to the home, these people will be seen by opticians. Few of the opticians have been trained, few of the opticians are brilliant, but not, it's very difficult to maintain the quality control. The person you are seeing who is doing isolated practice most of the time, making the glasses to sell you the glasses for a lot of money, they have started to take on some of the roles. If they are good, I have no objection as long as their pathways are correct. So we are trying to work and minimize the damage by engaging with opticians, trying to teach them. But more importantly, we feel we should be teaching our patients what they should expect. And what they should expect, what they should record themselves. About a year ago, we did facilitate the launch of Glaucoma Passport. But Glaucoma Passport, again, actually it's an original idea from Worcestershire, because it was Mr. Perry's idea. Mr. Steve Perry is one of the consultants in Worcestershire. But that idea, just like glaucoma, was stolen. And Glaucoma Passport came. It's a good idea, that's why I supported that. But that's again a financial, it's about £12. I don't think it's worth £12. And what we have done on our website, we will be showing a simpler way to record your pressure and keep record with yourself. Those who have got access to computer. That will come with the website. Coming back to the, where are we, how we are doing with time? Coming back to glaucoma. Essentially, if we don't want to reach to the stage when we have to do surgery, we don't want to reach to the stage when people are, their driving is threatened. So the whole emphasis is on education and prevention. How can we prevent? Those 93% of the people, if they keep doing the drops regularly and correctly, that's the most important thing. And are we able to do that in clinic? There's not always enough time because there are some urgent situations we are dealing with. That's why Glaucoma Support Group was formed largely to educate people how to do the drops correctly. So I'm going to invite now, you all know her. She is the founder member. I came to Worcestershire and I had this idea, and I spoke to Sarah, and she has really worked very hard on Glaucoma Support Group side of things. So I'm asking her to speak on how to do the drops correctly. This is the thing actually every one of you perhaps should revisit at least once a year, if not twice a year. But we'll first listen to Sarah now live, and then we'll see her virtually on the screen. Okay, Sarah, please go.
Good morning everyone, and it's really lovely to see so many of you here today. It makes me very proud for all the effort. So today we're going to talk about eye drops, which you all know is often the first treatment option in glaucoma. But what are eye drops? Eye drops are a sterile solution or a suspension of a medicine which is used to produce a local effect on the eye. In glaucoma, they're used to reduce the intraocular pressure, either by reducing the amount of fluid that's produced inside the eye, or by speeding up the speed that the fluid is drained out of the eye, thereby reducing the intraocular pressure. Drops come in a vast, huge variety of bottle shapes and sizes, which is ever changing, but the technique to put them in is exactly the same no matter what shape or size you have. I'm going to talk through the correct technique now, but please remember that drops are as important as any other medication that you're prescribed, and you need to read the information that's supplied within them. in correctly, and I understand it's a huge audience, so you may not be able to see me fully, and if you need me to, I'll meet in small groups afterwards and go through this again. So, you first of all wash your hands. Take the top off your bottle. Holding the bottle completely upside down, you rest your head back. Pull down your lower lid to make a pocket. Holding the bottle upside down, you squeeze either the sides or the bottom, or wherever on your bottle, because certain designs have to press in certain places. You're aiming to put one drop into the little pocket that you've made. Immediately close both eyes. Then with your finger you press on the inside corner here, pushing against your nose. This part of the procedure is called punctal occlusion. It's important that you keep both eyes closed to prevent the drop draining down your tear tubes, and you need to hold it here for at least 2 minutes. Then you release and repeat the procedure on the other eye. If you're using more than one type of drop, then you need to leave at least 10 minutes between each drop so you don't wash one out with the other. I'm often asked for tips. People say, I can't do it that way, Sarah. What can I do? The most difficult part that most people mention is finding to get their head back in the correct position. Now, I'm not often found lying down at work, but lying down is the best tip I can give you. If you can't get your head in a good place, try it lying down. Other people say they can't hold the bottle freehand. These are some variations. They're all completely acceptable. You can rest the your hand on your other hand. You can rest your hand on your nose. You can even rest the bottle across the bridge of your nose. All of these are absolutely fine. I'm going to talk to you again about punctal occlusion because this is the bit that I find everybody misses out, and it's an incredibly important step that prevents the drop going down the tear tube, draining down the back of your throat before it's had its full effect. I can't stress enough that you need to keep both eyes closed at the time you're pressing. You only press on one eye at a time. You can't double up and do it this way. It has to be one eye at a time. Remember that you need to hold for 2 minutes. It's a long time. It takes time, but it's better to do it properly. If you're having problems putting your drops in, come and talk to us. We have a huge range of aids available within the department, and we will try to find a solution to your problem. However, it's important that we carefully assess whether an aid will help you. The aids are made for different bottles and different problems, so do talk to us to make sure that we give you the right thing. Some hints and tips. It's important to establish a good drop regime. You will have been told the best time to put your drops in. Stick to the same time every day. Make yourself a chart, a reminder chart for you to tick off to know that you've put them in, or even set an alarm. Positioning your drops near something else also helps, by your toothbrush, by your other medicines. Use your drops in a set order, and then you will do the same every day. It becomes a habit. All the drop bottles start to look very similar, so you might find you need to put stickers or marks on the bottles so you don't confuse them. And if you use different drops for different eyes, you may find it useful to put them in different rooms so you don't muddle them. I frequently asked a series of questions within the clinic. When should I order my next prescription? You need to allow at least a week or two for your script to get through your GP system. So get into the habit of ordering a week or two in advance and make a note in your diary so that you get into that habit. How long do my drops last? Most drops have a 28-day expiry date, but you do need to read the information that's with them. How should I store them? Different drops require different storage, so read the information. What do I say if I'm admitted to hospital? As I said, drops are a prescribed medicine and you need to declare them as you would with any other medicine. What if my drops don't reduce the pressure? There are a huge range available